How do we define beauty? According to Plato, beauty and function in their perfect expression are synonymous. During the last 15 years, technology has evolved dramatically. More and more, non-surgical procedures for facial rejuvenation are getting a lot of support from the public. It has been established that the face is divided by the septum and different types of fat compartments located at different levels. Facial aging is in part characterized by how these separate compartments change as we grow older. Dr. Pesser from University of Texas Southwestern Medical Center said, "The face resembles a three-dimensional puzzle." Following this 3D principle, we analyze the patient using the 3D Vectra system by creating an avatar of the face. Vectra captures the anatomical shape by capturing stereo images of the subject, and then using photogrammetric algorithms to generate a high-resolution, three-dimensional computer model of the subject. Thanks to the advances in applied anatomy, we are able to individualize which part of our face is lacking or is aging. A key aspect is careful, individual preoperative analysis of each person's face. We propose this facial analysis algorithm using the natural landmarks found on the face to visualize what is missing, including asymmetries and subtleties that give every person a unique look. The goal: to bring support, volume, and to restore what is specifically missing, as opposed to filling holes. The face is comprised of 4 large fat pads. 3 are located at the mid-cheek level, referred to as the deep middle fat pad, cheek fat pad, infraorbital fat pad, and one at the lower lid called the retroseptal fat pad. 80% of cosmetic consultations are about the nasolabial fold, or NLF, and the tear trough, or TT. NLF is a natural and dynamic fold. Most often, its correction is related to the deep medial fat pad and not to the fold itself. Thus, we must evaluate the deep medial fat pad, as it is what gives support to the nasolabial fold and the tear trough. The tear trough appears due to the action of 3 muscles: the levator labii superioris, the levator alaquae nasii, the orbicularis oculi, and the diminished volume of the deep medial fat pad. By touching the zone externally, we confirm the zone to treat, and we avoid the cannula overshooting the serum or entering the retroseptal space. The cannula is inserted from the middle point of the nasolabial fold. It is introduced perpendicularly to the facial plane, touches the bone, and is turned 90 degrees upwards between the levator muscle of the labii superioris and the deep middle fat pad, passing underneath the orbicularis oculi muscle and finally arriving at the infraorbital rim. We initiate a series of infiltrations from the infraorbital rim using a small to mid-size filler particle, simultaneously restoring the tear trough and the middle fat pad in the form of an inverted triangle or stalagmite. We consider the cheek-lid junction, or CLJ, to be a dynamic point. As we age, the orbitomalar and palpebral ligament stretch down, creating a gap between the lid and the cheek. The goal is not to fill the hole or gap, but to fuse or to blend the lower lid and the middle cheek area to create a dynamic motion area. We must take precautions to avoid the zygomatic facial and infraorbital arteries and nerves. From the inferior lateral orbit, we insert the cannula using the pinch and pull technique to obtain the right layer, below the orbicularis oculi muscle. We reach the lateral infraorbital rim using the finger as a protection guide. If we observe the red filtration line that goes beyond the serum in the retroseptal area, we see that it is not only aesthetically incorrect, but dangerous. With a small to mid-size filler particle, we infiltrate, using the same stalagmite principle, over the arcus marginalis, blending the lower lid area and the cheek area. The goal here is to create blending or fusion. In order to treat the central infraorbital zone, we insert the cannula from the middle point of the nasolabial fold through the cheek fat pad. From underneath the orbicularis oculi muscle, we arrive at the zone and we proceed to deposit the filler in the same fashion, blending both areas. The single injection technique can provoke anti-aesthetic results, given that it simply fills the space and does not give natural motion. The key is to not leave drops or bolus, nor a long single injection, which can create a double fold when the patient smiles. The infraorbital fat pad, located at the triangle of lines 1, 2 and 4, is at the same time located at the point of maximum projection of the face. Close observation will reveal whether the patient needs projection or volume. To obtain projection, we need to correct deeper, close to the bone and with large particle size filler. The entry point for the injection is obtained by following one of the lines of the supratarsal fold. To proceed with the introduction of the cannula, we protect the eye with the thumb and index finger, coming into contact with the bone or the zygomatic process. Inject the filler without tunneling. Tunneling leads to greater chances of migration. Here, we notice the increase in projection of the cheekbone or zygomatic arc. In order to obtain volume, we need to correct in a more superficial layer using the pinch and pull technique and with a cannula. The cannula is inserted in the middle point of the nasolabial fold, arriving at the infraorbital fat pad, where we proceed to deposit mid-size filler particles. We notice the increase in projection on the right side and volume on the left side of the cheekbone or zygomatic arc. Once the fat pads are restored, we need to blend the 3 principal fat pads that comprise the entire cheek area. This area is crossed by the orbicularis oculi sulcus, called La Vallée des Larmes, or Valley of Tears. From the middle point of the nasolabial fold, blending correction is done using the pinch and pull technique with a cannula using vectors perpendicular to the cheek sulcus, thus creating the brick effect that gives support and volume. Fewer drops are left in the fat itself, and bigger ones are deposited at the sulcus all along the face until we obtain a smooth transition between inaction and movement. By using the filling technique, one only fills the depression, and this creates heaviness and less natural movement. Beauty does not reside in material objects, but in the eyes of the beholder, and above all else, in the evolution of how we perceive ourselves.